Hello, this is the continuation of Theory 7 and 8. This is primarily 8. This is Chapter 27. I'm going to talk about some intrapartum problems. Dysfunctional labor. Remember when we talked about the prefix DYS means difficult or painful or not effective kind of thing. And so dysfunctional labor, we can have different reasons for dysfunctional labor. One of them might be the powers. Remember, the powers is all about the labor contractions and so forth. We might have ineffective contractions. They never get to the point where they make any cervical changes or the baby fails to engage in the pelvis. We might have overdistended uterus with maybe multiple gestations or possibly hydramnios, an excessive amount of amniotic fluid. We can have hypotonic labor, hypertonic labor, and then of course ineffective maternal pushing where she's screaming and she's not using her efforts most efficiently. So hypotonic labor usually just means that, again, the contractions are ineffective and we're not making progress. And so we might have to augment the labor with Pitocin infusion. Hypertonic, on the other hand, can be quite painful. And in other words, the contractions are coming too fast. They're very, very hard. There's the resting tone of their uterus. Remember, the resting tone has to be down to the baseline if at all possible to give that muscle time to rest, relax, get full of blood again. And if they're coming too fast, they're coming too hard, then the muscle's going to suffer and the baby's going to suffer. Frequent prolonged contractions that are not productive, maybe they're just hard, but nothing's happening or the baby is not moving down. It's very painful, and again, sometimes it's just too much Pitocin, and so sometimes we just need to cut that down, or we may have to give some uterotonic medications. It just depends on your situation. So here's a monitoring strip of a laboring woman who has hypertonic contractions, and you can see, I hope you can see that there's a late decel. It's to the right of the contraction, so that's a late decel. The baby recovers pretty well, but if this continues very long in labor, the mother's going to suffer and the baby's going to suffer. We also have dysfunctional labor that's not effective with problems of the passenger or the baby. The fetal size. Remember, just because the baby is small doesn't necessarily mean it's going to come down any easier. So it just depends there. You may have a baby that's hydrocephalic and has a large head, and so we'd obviously probably do a C-section then with macrosomia. Oftentimes, if there's a chance this baby will not come, we'll just go ahead and do a C-section. Shoulder dystocia, which we'll talk about a little bit. Abnormal fetal presentation or position. Again, if it cannot be managed otherwise, we'll do a C-section. Multifetal pregnancies. Again, most of the time those are delivered by C-section. And again, the fetal anomalies might just be some odd things that are going on that are congenital that might prevent the baby from being born as it should. So here we have something called shoulder dystocia, okay? We got a big baby, possibly, and the head is born, but oftentimes the head may be born or it's crowning, but it slides back up, and it keeps sliding back up, and then it kind of is sort of delivered, but it's not quite there, and it keeps sliding back up, and that's usually because the anterior shoulder cannot pass through the pubic arch, okay? Now remember, the anterior shoulder has to be delivered first. So the newborn is more likely to experience birth injuries like brachial plexus damage, asphyxia, and maybe even collarbone fractures. And so that's a problem with the baby. The mother is going to lose a lot of blood because lots of times we may have uterine atony or even a uterine rupture. We have extensive lacerations and or episiotomies. And lots of times they cut pretty deep with that episiotomy to get that baby out until there's a lot of blood loss. As you see there, the woman in the top left picture is doing something called McRoberts, M-C-R-O-B-E-R-T-S, McRoberts maneuver, okay? We will have to help her with that because that seems to increase the angle. And remember that pelvis, or excuse me, that perineum is very soft. And so if we push down, it may be enough to get that shoulder out. And also, in letter B, as you see here, we have some suprapubic pressure being put on probably by a nurse in conjunction with the physician delivering the head. Forceps don't usually work because it's a shoulder problem. It's not a head problem. Okay, here's another picture of the same thing. As you can see, we have suprapubic pressure, and sometimes you see one hand on one picture, and the woman has her legs contracted back in that McRoberts maneuver, and then sometimes we have the nurse is actually putting 2 hands on that suprapubic area. This is a very scary thing. This makes everybody nuts. Everybody is running because we know if we don't get this baby out, this baby's going to die. And then we've been cutting mama, trying to get more room to get that shoulder out, and she's going to bleed. So this is a true emergency, and you are going to have to call for help. The other night at Freeman, they called a shoulder dystocia, and the NICU people, I was in the NICU, and the NICU people ran. I mean, they ran down there because they knew they could have a compromised baby. Well, thank goodness, nothing bad happened with it. It actually resolved itself, so we were happy about that. But oftentimes, it can be quite deadly for both. Other parts of the dysfunctional labor, sometimes the pelvis is not adequate size or shape. And oftentimes we'll find this out prior to delivery, and we'll go ahead and make plans for a cesarean. And then, of course, the psyche. We've got a woman that's terrified. She is scared to death. She's trying to get away. She is wanting to go home. We have to talk her off the ledge, so to speak, and calm her down, make eye contact with her, get her to focus. We don't medicate her necessarily unless it's absolutely necessary, but we definitely need to get her back on track, help her, be supportive, but take control, take charge, be the leader in this situation because, family members may not help. I know of male persons, I don't know what else to call them, who are there when this happens, and they scream at her and tell her to calm down, behave yourself, and the mother does too. And oftentimes it's just a terrible, terrible situation, and people need to understand this is a terrifying thing, and it's very real to the patient, and we need to be supportive and helpful in this situation. Okay, then other parts of the dysfunctional labor picture is abnormal duration. We have a prolonged labor. Generally, it depends on your physician and your policies and so forth, how long they'll let a woman labor, all right? Oftentimes during labor or prolonged labor, she has either already ruptured the membranes or we do it for her. And so automatically that is an avenue for infection. So we worry about infection. We don't want her to labor too long because she could get infected, which would lead to neonate, okay? Infection. The mother becomes exhausted. I mean, I recall my 18-hour labor. She's 37 years old, but I remember lots of it. And so you are exhausted. Even if you're not pushing, you are tired. So these are ways that labor can be dysfunctional. Also, we talked about the level of anxiety and fear can be a problem in this situation. Now, on the flip side of this, a precipitate or precipitous labor, a rapid labor that occurs within 3 hours of onset labor, and you say, oh boy, that'd be the way to go. No, because that puts a lot of strain on mama, and that puts a lot of strain on baby. You're more likely to get lacerations and tears, and all kinds of bad things. So 3-hour labor or less is very, very dangerous to both. And then if you run into a shoulder dystocia, then you really got trouble. So a precipitous labor is not a good thing for mama or baby. All right. If a woman tells you my baby's coming, you better listen, especially if it's her second or third. All right. It's coming. So be prepared. Have your emergency equipment available. That's all, in any labor and delivery area, you've got an emergency cart. You should have suction in your room. You should have anything available, oxygen, anything available. You need to make sure when you go on shift that you check it, make sure it's functional. Nobody gets crazier in a bad situation if the suction doesn't work. Oh my goodness. So be sure you check all this before you take over your care or as a part of taking over your care. Make sure your equipment works. I cannot stress that enough. Now, another emergency that, or potential emergency that I did not see in the book. If I missed it, please forgive me. Maybe you'll find it and point it out to me. But I did not see anything about meconium-stained amniotic fluid. All right. This indicates the fetus has passed the stool prior to birth. Now, sometimes it's a result of just natural BM, okay? But most of the time we think about it being a sign of hypoxia. There's hypoxia resulting in relaxation of the anal sphincter, which causes the baby to pass a stool. Now, it's possible it could be a breech presentation, but it also could be a sign of fetal hypoxia and sometimes umbilical cord compression. So we'll talk about that in a little bit. So if it's a slight green stain, we watch it. We have that external fetal monitor on. We're watching that fetal tracing. We're watching for any signs of fetal distress. If it's dark green, oh my goodness, we need to let NICU know. We need to let the doc know because that baby could aspirate that fluid. And I know that at times we've had a meconium stain, heavy meconium stain, we call it. It almost looks like green pea soup. It's just very, very green. And so when the baby is born, they do not even suction the nose of the mouth. They go ahead and visualize the vocal cords. And if there's meconium staining, they'll delay the cry for a few seconds to clean those cords out because we don't want them to aspirate that into their lungs. It's a deadly, deadly thing. So it depends on how bad it is and the skill level of your provider. Some docs get real nervous and start suctioning, and that makes the baby cry, and who knows what they've sucked down. So it's better to delay the cry a little while. So before we check those things. And so we have, again, if you have this situation, alert emergency personnel, get some help in there, make sure everything is ready to go. You've got a neonatologist on standby, possibly your NICU people on standby, and you're ready to take care of this meconium stain baby. Okay. Important to remember, meconium stained amniotic fluid. If it's in your book, please find it for me because I missed it. Signs and symptoms that are associated with intrapartum infection, which can happen as a result of premature rupture of membranes or just rupture of membranes. Premature rupture membranes, we'll talk about a little bit more here in just a minute. But when a woman has an infection, it's going to show up in her baby as well. It doesn't mean the baby's infected, but they're going to have the side effects of mama's infection. Most commonly is your fetal tachycardia. You've got, remember a normal fetal heart rate is 110 to 160. Well, it'll be 160 at least or above. Okay, you're going to have fetal tachycardia. You're going to have maternal fever, 100.4 or greater. Foul or strong smelling amniotic fluid. Okay, cloudy or yellow amniotic fluid. So all those things are indicative of an intrauterine infection, which we call chorioamnionitis or possibly afterwards endometritis. So those are not good things. And so we see these, we're going to take care of this and treat it accordingly. And again, we're going to watch that baby very, very carefully for any signs and symptoms of distress. Watch mama, depending on her level or her week of gestation. They may not mess around. They may go ahead and deliver the baby by C-section or possibly a trial labor. It just depends on your situation. But either way, this is a serious thing. We need to keep very, very close eye on mama and baby in this situation. Premature rupture of membranes, PROM. It's a rupture of the sac before the onset of true labor. So breaking your water or your water breaking doesn't mean you're in labor. It just means your water broke, because it can accompany labor, obviously. But premature rupture of membranes before labor starts is could be a problem. Then you got PPROM, preterm premature rupture membranes before 37 weeks gestation. Okay. Now, breaking the membranes does not necessarily mean labor is going to start. It could. Okay. Some women before 37 weeks break their water and have no contractions. This is not good. We don't want them to do that. But again, it can be associated with preterm labor, because oftentimes breaking the water will start contractions. Not always, but it can. Another problem with that is chorioamnionitis can be the cause and result of premature rupture of membranes. The body's trying to rid itself of something infectious. Okay, so when a woman comes in with premature rupture of membranes, or they think it, they're going to test it to see if indeed it is premature rupture, if it is amniotic fluid. And so they may do the litmus paper test, and they may do the fibronectin test. So there's different ways we can determine if it's amniotic fluid, or it could be urine. It's not uncommon. So especially in first-time mamas, they get really worried. Or a woman who's had several miscarriages, and she's worried that she's going to lose this baby too. So again, it should be investigated. And again, if it's premature, preterm rupture membranes, sometimes they'll let them, they'll keep them in the hospital, watch them for infection, trying to prolong the pregnancy, because remember, the longer baby's in there, the better. But we also have to be very aware of infection risk as well. Okay, so preterm labor. We like to say that more than premature, okay? Preterm labor begins after the 20th week, but before the end of the 37th week, okay? Now, there is research or resources that say that a pregnancy is viable. The baby will live at 20 weeks. It's very unlikely. The other night we were in NICU, they had a 23-week gestation. Tiny, tiny, tiny little guy. And I hope he's doing all right. We'll find out tonight. Anyway, sometimes there's not always real good indicators that preterm labor has started, because remember, women have Braxton Hicks contractions, and they may think that's what it is. Okay, and so if there's ever any doubt to the fact that she might be in preterm labor, we're going to educate her. Hey, if you ever have a doubt, you go ahead and come on into the hospital. We'll evaluate you. If it's not, we'll send you back home with instructions and tell you what to do. That's what we need to do. Sometimes we're going to have irregular contractions. We may have some back pain. We may have some bloody show. It just all depends on how your patient presents. But if there's ever any doubt in her mind that she could be in labor and it's way too early, she needs to come in. Okay? Of course, if she's broke her water, then you've got the infection piece. And again, those manifestations we just talked about, cramping, maybe bloody show, some contractions, back labor, all kinds of things could present, but it's way, way too early. Okay, way too early for this baby to be born. Now, this is from your book. Late preterm is not term. Okay, a term birth occurs after at least 37 weeks to 41 weeks. All right. Late preterm are 34 to 36 completed weeks. Late preterm infants may appear to be full term at birth. They may be just big babies. The appearance is deceiving, okay? Despite the fact that the baby may weigh 7 pounds at 34 or 35 weeks, that doesn't necessarily mean that the lungs are mature, that there's no risk of infection, blood sugar issues, temperature issues, all of those things. So more than likely, this baby will go to the NICU as a precaution, all right? So don't be fooled by that. So mortality for late preterm infants is 3 times higher than that of term infants, because, again, the size could be deceiving. And initially, sometimes babies may come out and they seem to be okay, and then 24 hours later they're not doing well. So, and we can't always explain this, but it is a possibility. And so we are going to be aware of that, and we're going to make sure that we do not take care of this baby as a term infant, 37 weeks or greater. All right. So how do we manage preterm labor? Well, first of all, there's different ways we can go about making sure that we can make sure that this is preterm, and how we can kind of determine how we're going to handle this. The cervical length, and we're going to go by the Bishop score. We had that back in another class session, so you might want to go back and look at that a little bit. Again, we can do the fetal fibronectin test. It's a sterile procedure. We use a sterile speculum. We use sterile gloves. We use sterile equipment to get a little bit of amniotic fluid, if we can, to determine if indeed, and there's a certain test that they run on it. We're also going to watch for any kinds of infections. Women who are at risk, we're going to identify, and oftentimes this just means that we're going to have more frequent prenatal visits. If someone has a history of going into early labor, they're going to be monitored more closely. And there's risk factors, I believe, listed in your book, if I'm not mistaken. Let's see. Okay, we'll find that out. So what are we going to do for this lady? All right. So what we're going to do is we want to suppress uterine activity. All right. We want to stop those contractions if we can. All right. And I'm going to give you a little acronym for you to remember. It's called INMT. INMT. And that stands for it's not my time. All right, it's not time for me to come yet. So one of the drugs we might use, although it's not used as often as it once was, for that first I is indomethacin. INDOMETHACIN, also known as Indocin, INDOCIN. It's an NSAID. It has been shown to be effective in stopping preterm labor contractions. Again, it's not used as commonly as some of the others I'm going to tell you about, but be aware. Another one for the NIN, nifedipine, NIFEDIPINE, which is technically a calcium channel blocker. So think about the role of calcium in muscle contraction. Okay, we use that sometimes. Now this is short-term therapy. All right, short-term. We only use it till we hopefully see those contractions go away. All right, 2 to 3 days at the max. All right. Then we also have magnesium sulfate. Is also a uterotonic. Okay, it slows down those contractions. And the last one is the T, terbutaline, TERBUTALINE. All right. So terbutaline, of course, is classified as a respiratory drug. All right, but we use it to suppress uterine contractions in preterm labor. Okay, so terbutaline, of course, we know we're going to tell mama, hey, if you use this and we're going to give you this, it's going to make your heart race. Okay, you're going to feel like your heart's beating out of your chest. You may feel a little jittery or crazy. It's a side effect we expect, and we're going to help you with it. We're going to watch your baby. We're going to watch you. Again, these drugs are used only in the hospital primarily and for short term. All right. So we want to try to stop those contractions if at all possible. If it looks like we are not going to be successful, or we just want to make sure we're being a little proactive in our approach, we are going to try to promote fetal lung maturity. All right. We can give antenatal or in pregnancy glucocorticoids. Okay, this significantly reduces the incidence of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and death in neonates. All right. So we may go ahead and give some steroids. Okay, we can give surfactant. We can give surfactant to the baby after they're born. So there's some things we can do now. we also have to prepare for what could be a fetal loss, okay? The baby may be 20, 21, 23 weeks, whatever, and we cannot stop it. And it's being born, and unfortunately, it may not survive. So I'm sure this is probably on the mother's mind all the time. My baby's coming too early, it could die. So we have to be very supportive. We have to watch our demeanor. We can't go in bebopping in the room, acting like we are high on something. We have got to be professional in our behavior, in our talk, in our therapeutic touch, and explaining and helping these parents deal with a possible, it may not happen, but we always have to be prepared for a fetal or early neonatal loss in this situation. All right. So sometimes, again, using the cervical length and the fetal fibronectin might give us some clues as to indeed is this preterm labor. So we have some things that we can use, and hopefully, if this woman is in an outside area, a small rural hospital, they have a direct line to a tertiary area there where they can take care of this NICU patient. The NICU people will come and pick it up and take it if that's what's indicated, and so forth. But best case scenario is, of course, to stop the labor. Now, sometimes the labor, if there's premature rupture of membranes preterm, then we may not have an outcome like we like, but it's possible. We can try. Prolonged pregnancy, or we call it post dates sometimes. It's one that's longer than 42 weeks, okay? Sometimes the estimated date of delivery is just, our dates are wrong, but sometimes they're right and we just have a prolonged pregnancy. The problem with that is pretty soon the placenta is going to wear out. It just has a shorter life than that, and so it may start to give out. And then you may have meconium problems, and then you may have a dystocia problem because you've got a great big baby. Hey, cut that out. My cat is acting up this morning. I'm going to beat her. Anyway, so this pregnancy is going too long, and when babies are born like this, oftentimes their skin is kind of peeling. They're big, they're lethargic, they have blood sugar problems. They could have dystocias again, like we said. So it is not a good thing. So if a woman's approaching 40, 41 weeks and it doesn't look like she's going into labor very soon, and they check her cervix and it feels favorable, they'll probably go ahead and induce her and get that baby out if at all possible. Okay, intrapartum emergencies. I'm going to talk about this more in class, the placental abnormalities. It's just because of the hemorrhaging part. I'll talk about these a little more in class, so we will skip this one for right now, and we'll talk more about it in class. All right. Another intrapartum emergency that you really don't want to ever have is an umbilical cord prolapse. Okay, the umbilical cord slips down after the membranes are ruptured and becomes compressed between the fetus and the pelvis. All right. Now, sometimes it can be that way without rupture membranes, but it's more common for it to do after the membranes have ruptured. Prompt delivery of the fetus remains a priority. That cannot be stressed enough, because if you've got an umbilical cord compression, you're going to have a dead baby if you don't do something. Number one, we have to relieve the pressure on the cord by various means, and we'll see that in just a minute. And delivery must be expedited or quickly done, one way or another. Okay? So, what we're going to do, talk about the risk factors for a prolapsed cord. Ruptured membranes, automatically, especially early in the pregnancy. The fetal presenting part is at a high station, okay? It's a -2, a -3. It ain't even at a 0, all right? So it's up there, it's floating around, and then the amniotic fluid breaks, and whoops, here comes the cord right by it, okay? A fetus that fits poorly in the pelvis because of a small size, remember that small size baby isn't always a good thing, or some sort of abnormal presentation, not occiput anterior possibly. And then we have excessive volumes of amniotic fluid, lots and lots of fluid. It gushes out and the cord just kind of falls out with it. which is not a good thing, obviously. So here's pictures of different types, variations of how it can present. We call it occult or hidden. We have the cord prolapse in front of the fetal head. It actually protrudes out of the vagina. And then we have a complete. All right, so there's different ways it can present. Here's another picture. As you see here, the cord is coming before the head. All right. Another one. Just more pictures of the same thing. Okay. So we've got to get pressure off of that cord. All right. We've got to get pressure from that presenting part that's on the cord. All right. So what we're going to do, well, number one, as you see here, sometimes a woman can feel it, sometimes she can't. Sometimes you'll see a sudden change on your fetal heart tracing, and you go in and you look and you go, oh no, and you put your hand down there, put a sterile glove on, and you feel it, and you're going to have help. Stat. You holler out, cord. Everybody knows what that means. Everybody who works in labor and delivery knows what cord means, all right? So you see in that first picture, the nurse actually has her hand in the vagina, kind of lifting, if at all possible, that presenting part off of the cord, all right? Then if she can, most women can't do this, but we'll try it if we can, we'll get her into a knee-chest position, which is going to use gravity to pull the presenting part off of the cord, and we're going to take her to emergency delivery, either possibly by C-section or maybe forceps, but more than likely C-section. Okay, we don't want to take any chances. And then you got the sideline, which may or may not work. I've seen the knee chest more often, and I myself have hopped on a cart with my hand in a lady's vagina holding the head up off the cord. And down the hall we went to delivery. So you got to get the pressure off by some means, okay? If the cord is protruding, don't try to stuff it back in there. That will not work. Have someone bring some sterile saline soaked gauze, and you can just lay it on there to keep it moist while you're, if you've got your hand in there. If you got her up in the knee chest, get her to delivery ASAP. Okay, that makes people move really fast when you have a cord. Uterine rupture, thank goodness, is very rare. It's more associated with the incisions we used to make on incision on C-sections that went vertical rather than the bikini, what we call the bikini cut or the phanastile, we call it. It's more common there, but it can happen after multiple gestations. The abdomen is very, very tender and board-like. They can actually have that chest pain or pain in the shoulder area, kind of along the lines of that ectopic pregnancy we talk about. There's bleeding. The uterus has ruptured, it's bleeding. And there are signs and symptoms of hypovolemic shock. The fetal heart rate might not be there at all. And contractions have ceased. And sometimes you can actually palpate the fetus outside of the uterus in the abdomen, which is very bizarre. I've only seen one in my entire career. And this is kind of what it looks like. The early presentation, the previous incision site for cesarean has split because of contractions or trauma or something like that, and it tears along the site of the scar and it bleeds, and the baby is not getting oxygen. And the only one I ever saw, we saved the mama, but the baby died. Okay. Uterine inversion, again, is something unusual, but we have to be aware of it. It occurs when the uterus is completely or partially turned inside out. This can be prevented by proper hand placement of the hand over the suprapubic area, secure, when we are massaging the fundus. Okay, it is possible, not likely, but it is possible to actually push so hard you can push the uterus out. All right, is not good. This is an emergency. It's possible she may have to have an emergency hysterectomy. So we need to really be careful with that. Obviously, she's going to lose lots of blood. Uncommon, but potentially fatal. Recovery care that promotes uterine contraction and maintenance of adequate circulating volume. Okay, we're going to have to do something with that. It's not a nursing problem. We've got to alert people, do the supportive care that we would do for our patient, vital sign support, fluids, oxygen, get help. They're going to have to, the surgeon's probably going to have to do something with that. But oftentimes, again, it's because of really vigorous pushing on that fundus and pushing it inside out, which is awful, but hopefully it doesn't happen. And our last condition, as far as obstetrical emergencies, is something called, not the last one, the second to last, sorry, anaphylactoid syndrome, okay, also known as amniotic fluid embolism. Again, this is very, very rare, but it happens, okay? Amniotic fluid is drawn into the maternal circulation and carried to the woman's lungs. It presents a lot like a pulmonary embolism, chest pain, shortness of breath, falling O2 sat, EKG changes. It looks like a pulmonary embolism, and it's a lot like that. And cardiopulmonary resuscitation, oxygen, they may have to be ventilated, correction of hypotension, and they're going to have blood component therapy, and we just do the supportive care until they get better. That's really all we can do. Again, it's very, very unusual, but it can happen. And our last one is about trauma to the pregnant woman, especially if she's term. More caused by motor vehicle accidents, assault, or suicides. Women are far more likely to have episodes of domestic violence inflicted upon them when they're pregnant because they are viewed as helpless, and oftentimes they are. Motor vehicle accidents, assaults, suicide. Also, don't forget that separation of the placenta, or there's hemorrhage, can also be associated, again, with use of cocaine during pregnancy. And you say, why would they do that? Well, that's what they do, unfortunately. You treat it just like a non-pregnant person. Cardiopulmonary support, control the bleeding, careful evaluation of the uterus and the fetus. We may or may not be able to have a viable birth, but we certainly hope so.